So one of the questions that I forgot to go over was who mixes the Botox? I asked the question, we didn't get an answer. So, and I'll allow some of the panelists to chime in, but in my office, we have one dedicated technician who's very well trained to do this. And if he or she are out, then I do it myself. And because every patient, when we talked about the volume and dosage, it's a little bit of sort of dilutional chemistry. You have to know exactly what you're injecting. But it's even like you have to make sure it's preservative, bacteriostatic saline, that it's not lidocaine that they're mixing in, that they're drawing out the right amount, that they're changing the needle. You know, we don't use the same needle where we draw the material out of the Botox bottle and inject the patient because that needle is dulled going through the rubber. So we use a fresh needle because a sharp needle hurts less. So there's a lot of little steps, and you really have to make sure you have a well-trained technician to do it, and if they're not around, the physician does it themselves. And if anybody else can chime in.
Yeah, I agree. There's one there, you know, at Wills, I think, you know, we're lucky we have technicians that are very used to doing it. So when I'm there, oftentimes they do mix it up, but I go to a few other offices and I always do it personally, you know.
Yeah, there's a lot of steps and things can go wrong with each step, so we were very, very careful. So what type and dose of omega-3 is recommended?
That's a good question. I often will have patients just use a lot of, there's a couple different ones. One is called PRN Pharmaceuticals, and I apologize, I don't know the dosing offhand, but that is one that's been targeted specifically for dry eye. There's a couple other ones out there. I honestly don't recommend omega-3 to a lot of my patients, I'll be honest. Just because I haven't had it be super successful. So I let them kind of find the supplements that work for them, and I just tell them to supplement their diet as well. The data, in my mind, has been pretty mixed on supplementation, but in healthy diet of you know, fatty fish and things like that, I don't think you can ever go wrong.
Can I follow that up with a question? So you said no supplements. I have many patients also ask about flaxseed supplementation. You don't recommend that either?
Again, I have to look deeper into this, but from what I've seen, there's, depending on which supplements, that's part of the mix of data, and that's a lot of specialists say certain supplements might work, others may not, and so it's hard to broadly recommend a supplement class. So the ones that I've seen work best have not been the flaxseed ones, but I haven't looked deeply enough into it to recommend one particular product.
What's the difference between blepharoplasty and partial myectomy? Gigantic. Go ahead, guys.
I think
Had a lot of
many
time.
of us can weigh in on that. So if you're just doing a blepharoplasty, as I mentioned, you are removing a little strip of orbicularis, but it's a very small amount. In a true myectomy, you want to get every little strand of orbicularis. So that's extending basically all the way from the brow down to the lashes as well as the lower lid. So a myectomy is a much bigger procedure. More incisions, especially if you're not staging it, and you're really trying to remove all of that muscle. A blepharoplasty is not going to give you the functional effect of a myectomy. I don't know, Dr. Bilyk or Dr. Watson.
I think that's very important when you talk to your surgeon, because I'm sure we've all seen, and I've seen multiple patients that will come in and say, I had a myectomy and I'm still having spasm, and when you read the op report, it's pretty obvious it was basically a blepharoplasty. And that doesn't get anywhere near the amount of muscle you need. I mean, a myectomy is a long procedure. It's a meticulous procedure and a somewhat frustrating procedure because you need to strip all that orbicularis. Alison, do you have anything to add?
Yeah, I don't think I really have much to add. I mean, and in a traditional blepharoplasty, often I'm not removing any muscle at all. You know, sometimes I try and preserve it for non-blepharospasm patients. So two very different procedures, and in 2 years that I've been in practice at Wells, I've been able to talk everybody out of it. So
yeah, I mean, it's you know somebody's
sure
you know somebody's done a lot of myectomies when they try to talk patients out of it. And it's not a bad procedure. You just got to be really careful to pick the right patient. And if you do, then your success rate's better.
Yeah, alas, I haven't come to the last resort yet. For
Yeah,
most patients.
yeah. So photophobia, light sensitivity is a daily challenge, which we all have strategies we use to address. Why is it such a big problem for patients with blepharospasm?
I don't, again, I don't know that I'm the most qualified to answer this. From what I've read, the understanding of the photophobia, again, goes back to those retinal ganglion pathways. I don't know why it's particularly severe in blepharospasm. I have plenty of dry eye patients that have photophobia in some regard, but as you saw from that paper, it's clearly worse in patients that have dry eye and blepharospasm. As for a reason why, I'm not so sure.